headache discussion, and you can, of course, recognize some very early work from Ray and Wolf in the 40s. Fascinating paper about the anatomy of innervation of the skull and link with headache. So Dr. Perez mentioned already my volunteer work, but I also work as a consultant with the industry. And you may have heard that in the world of migraine at present time, there are numerous new treatments that are biological agents. And so I work with all these companies. So I thought before starting the objectives, I think the first key statement to make is that migraine is the bread and butter of the headache clinic. And this is a study done in the UK showing that migraine dominates really what we see. Tension type headache, I have to say, I don't see that much. I think it's a quite rare that tension type headache people are sent to the headache clinic. And then, of course, cluster headache, I will say a bit about. Secondary headaches is actually a very wide chapter, but much less prevalent than migraine. This includes intracranial pressure problems, CSF leaks, CNS lesions, post-traumatic headache, and a bunch of other things. The classification of headache disorders has 214 diagnoses plus the appendix. So it's a lot of different stuff, but bread and butter is really migraine, and that's what we see. And so for that reason, I will do a little update about migraine and especially new therapies because I think it's important that to share that with you guys. I will talk about chronic migraine and some overlap with the chronic pain world. I wanted to say a few words about cannabis for migraine because I know cannabis has been a major change in our practice since its legalization. Cervicogenic headache, chronic cluster headache, and some complex cases and how to collaborate between the pain clinic and the headache clinic. So it's an ambitious program, and I hope I can go through all of these topics with you today. So migraine is, it's really it's actually the third most common disorder in the world after tension type headache and dental caries. Extremely common. It's estimated that 11% of the world's population lives with migraine. So in Canada, it's estimated that 25% of women of fertile age live with migraine. So that's one household over four. And it's actually a significant cause of disabilities. So according to the recent WHO report, just migraine is the first cause of years lived with disability below 50 years old, above every other condition. And that seems a little bit like an excessive claim, but migraine actually starts very young. It affects people during their whole lives, and the attacks are disabling, and it is extremely common, right? But in due and out of fairness, I think we have to remember that most of migraine people are not severely affected, myself included. I have low frequency episodic migraine. So the majority of people with migraine have a few attacks per month. And these people might actually never come to medical attention because they might just self-treat with over-the-counter, read here and there, and they might never need any prevention or high-level care. But if we look at chronic migraine, that all of these patients deserve care and are comorbid, that's close to 2% of our population. That's a lot. And if you add the high frequency people, that's kind of a lot of disabled people out there. So migraine is common. And then can we ask, is migraine a pain disorder? Well, obviously it is because it's a headache, so there's pain. But I would say it's more than a pain disorder. It's probably a whole brain disease because there are so many different neurological symptoms associated with it. And so this map here, there are many versions of this. So migraine, especially in its episodic form, is a mix of attacks. So it's a paroxysmal disease and interictal state. And I say this because often we call chronic migraine based on frequency, but all migraines are chronic because they go over the lifetime. So it's a bit like asthma and epilepsy, but it's also an episodic paroxysmal condition. So even basics like this are still a little bit confusing. So the typical migraine attack is a mix and match of pain with sensory hypersensitivity, gastrointestinal problems, autonomic manifestations, cognitive and emotional perturbations, and sometimes also vestibular problems. So that's actually a very complex disease. So let's have a look at this here, because I really wanted to do an update on the pathophysiology of migraine. And it is a puzzle. It is not an A to B thing. In the old days, you might remember there was a lot of controversy about, is migraine a vascular headache or something, a neuronal problem? It's both. So there are so many elements to this puzzle. So let me just walk you through this. Neurogenic inflammation is actually the cause of the pain during the attack. It's release of peptides near the meninges and arteries. So that's probably, most probably, where the pain comes from. Serotonin is low in between attacks and rises during attacks. So this is something we know as well. There's a lot of attention now paid to the mitochondria, and the oxidative stress in migraine, because most triggers of migraine attacks are known to raise oxidative stress. Genetics have been exploding over the last few years. Many polymorphisms have been related to migraine patients, acting on vascular function, neuronal function, and pain modulation. Cortical spreading depression is a wave of electric and ionic abnormalities going to the cortex. It is the basis of the famous aura. So not all migraine people have it, but it is highly irritable. There's a lot of genetics there. There are channelopathies. We have dominant genes causing auras, hemiplegic migraine, and also vascular problems can trigger auras and in specific patients. So it's another piece. The migrainous brain is also I won't say hypersensitive because that's not correct. It is actually, it has a low habituation to stimuli. So the migrainous brain, when exposed to repeated light or sounds or smells or movement or anything like that, will actually not turn them down. And that's most probably a very central process. fMRI has actually been done to see the migraine attacks connectivity. And this is recent data. And this is just illustrating what has been found, which is connectivity between the hypothalamus, the trigeminal nucleus caudalis, and then the pons, which this is actually very near the serotonin nuclei and the PAG. So there's a lot going there. And this study really, for the very first time, we could kind of replicate older studies and see the migraine attack. And of course, there's, the pain matrix modulation, so central and peripheral sensitization that is well known, well studied, and I think very familiar to you because a lot of studies are made, of course, on peripheral nerve injury and disorders in that area. So we've really jumped ahead in our understanding of what migraine is. If I can show you this, so this is actually where the pain comes from. So the thing missing on this picture is the dura, so the meninges, and the dural arteries. But overall, so the arteries are there, and you can see all the interaction and the release of neuropeptides, interaction with TRPV1 receptors, serotonin receptors, and they mention actually Botox there. We'll talk a bit more about Botox later. So when patients say that they have problems in their eyes and their sinuses and their temples and their necks, it's usually a lot of this is coming from the inside of the skull with referred pain from dural afferents is what we think now. All right, so this was for pathophysiology. This is how we approach migraine. So the first thing we do is we try to document what is the typical symptoms. Is there aura? What's the frequency? Is this a frequent episodic, or is it a chronic? What's the severity of the attacks? Is there overuse? What are the triggers? Is this menstrual migraine? Is this vestibular migraine? So the migraine family is actually quite complicated, and it's important to understand very well the phenotype of your patient, because that will drive your treatment. And then you look at the medical and psychiatric comorbidities. All doctors do that, but I will say that it's particularly relevant for migraine in the choice of therapy, and of course in the prognosis of the patient, when they are highly comorbid. Lifestyle is basic in all migraine clinic. We ask most our patients about it, because then maybe we can act and counsel. And social function is very important, because migraine is extremely disabling. Many patients are actually off work or miss work. And it's very important to understand you know, how the patient understands the attacks, what is the level of health literacy, what is the social support system, what are the stressors ongoing in the person's life, and of course, insurance stuff that may play a role both for drugs and for workplace. So that's we do the map, and then we do a menu. So we just kind of a three-pronged approach to treat the migraine patient. So we all address lifestyle and behavioral things. I'll show you some more. We do acute treatment and prevention. For the record, many patients who come to my clinic have absolutely no idea what's the difference between acute and preventive management after 20 years of living with migraine. So there's a very high need for education. Overall, you know, there's a lot of these patients live in a world where they're told by numerous people that the cause of migraine is chocolate or stress or hydration. And I try to explain to them that the migrainous brain interacts with the periphery, which is everything else, the hormones, the diet, the sleep, the sinuses. And so what we want is really stabilize the brain so we can raise the threshold of the brain and we can decrease the migraine load. And stabilizing the lifestyle is actually good for both. And then medications will, of course, contribute to this stabilization. So we do a lot of tailored behavioral intervention in migraine clinics. The big problem is that there's no resources, and this is me with my advocate hat. There are resources for asthma, there are resources for diabetes, there are no resources for migraine at primary care level. And I think this is something ideally in the future will improve, because therapeutic education is very important for pain and for migraine. But the ministry will not pay for it. They will pay for $800 MRI with absolutely no use, but they will not pay for a nurse or a psychotherapist or an occupational therapist. So that is something that is, I think, very important on a bigger level. I don't want to spend too much time on acute treatments for migraine, but just to underline two things. First, it's been a long time. Sorry, there's some fire going on here. Okay. It's been a long time in migraine. We've been avoiding narcotics because we knew they were causing medication overuse and sensitization for our patients. So for us, it's really all about NSAIDs and triptans. It's interesting that triptans will not treat other pains, to my knowledge at least. They are serotonin agonists. They do nothing for pain. They treat really, there are migraine specific drugs, but triptans have limitations. They do induce sensitization. They lead to medication overuse, headache. There are non-responders, and they are also very mild vasoconstrictors, which leads to some contraindication. So the future of migraine therapy is probably GPANs. GPANs are CGRP receptor antagonists. They are not in Canada yet, but they will come probably over the next 2 years. And GPANs might actually break the medication overuse headache dogma, because the more you use them and the more you get them as a preventive agent, because they're actually used both for prevention and also acute. So that's going to be a big shift here, because we've been telling our patients for years to watch their use of acute meds, to limit their use of acute meds, telling them they would sensitize, they would develop rebound headaches, and GPANs might actually change the whole game. So that's going to be great. Also, they're not vasoconstrictors, which is very helpful, because then the contraindications are not going to apply to them. Dietins are a bit less of a new novelty, but they are serotonin 5-HT1F agonists. So they are not vasoconstrictors, but they do have other problems, including dizziness, driving limitations in the US, potential for abuse due to weird euphoria. But they are still a very interesting option that's coming to the market in the next 2 years. But as you can see, I didn't mention cannabis. I'll say a few words later. Antiemetics are used as adjuncts or IV in the emerge. Caffeine is great for migraine, but everybody drinks way too much of it. So usually we try to steer away from that. Prevention. So prevention, this is just based on our guidelines. This is what we do, bread and butter. Our guidelines are outdated. We are in the process of doing an SLR with the Canadian Headache Society to review them. Botox are not in the guidelines because it was only for chronic migraine, and our guidelines was on episodic migraine. So this is really what is in the guidelines, but here is now what we are doing. So what we are doing now in a nutshell is we use first-line oral preventives, tricyclics, beta blockers, candesartan, topiramate. Um, Venlafaxine is overrated as a migraine preventive, in my opinion, and in my colleagues' opinion. So usually we do not use a lot of it, but sometimes it works. And then once you've failed 2 or 3 of these, then you can move to Botox and CGRP antibodies. And I'll say a few words about these. And then if these don't work, then you move to other options that are poorly tolerated, such as flunarizine, pazotifin, valproate. Gabapentin is okay, it's just it's not very effective. So this is really the what we are doing at present time in a very, very simple form. So chronic migraine, and now shifting from the more episodic patients to chronic, and this is where I think episodic migraine is a neurological disease with pain, but chronic migraine probably shares a bit more overlap with chronic pain principles. So usually patients start with occasional migraines, and they may have risk factors which are listed here, and then something happens over weeks, months, or years. They chronify and then they self-perpetuate. And this is something that I think is really common to pain and migraine. The risk factors, for example, adverse childhood events, other pain disorders are risk factors for chronification, sleep apnea, obesity, depression, low socioeconomic status. All of these are risk factors. And I think this kind of vicious circle of pain with sleep and medication overuse and muscle tension is something that we see in migraine, and that it's very similar to what you probably see in the chronic pain clinics. But even in there are different degrees, right? So, and I won't go through all the slide, but it's just to say that look at all the parameters. They can be mild or more severe. So if you look at the heavy chronic migraine patient, compared to a light chronic migraine patient, for since when they're chronic, what's their childhood, what is their level of education and literacy in healthcare management, how many accidents have they had, what's the relationship story, do they have headache-free days, or are they constantly in a migraine state, the severity of overuse. All of these parameters can be mild, moderate, or severe. And if we take someone like the heavy patient on the right side, this patient is going to be quite difficult to manage and may actually require multidisciplinary approach. Medication overuse headache is associated with chronic migraine, and this is one other interesting overlap we have with chronic pain world, because our model for overuse is actually allodynia in rodents. And this is a study done by the famous Mayo Clinic lab of Dr. Poreka and colleagues, who have a model of a rodent exposed to different priming agents, could be morphine, could be triptans, and then they induce allodynia with a nitric oxide donor, which is kind of, I think it's specific to migraine, and bright light stress. So, and they look at the orbit and the hind paw. And in this study, they showed that the CGRP antibody was reversing allodynia. So it's just to say, but this is the model we have for medication overuse. And I think it's just an interesting overlap, I think, with the allodynic studies that are also applied to other pain disorders. Right, so coming back to our oral preventives, the hard truth is that this study was a very depressing study, but I think it was a hard, crude look at our oral preventives. At 1 year, 75%, actually 80% had stopped them. So they're because they don't work or because they have side effects. And so that's the reason why chronic migraine is so depressing and was so difficult to treat, because patients were not happy, doctors were not happy, drugs were just not worth keeping, and patients were left with disability. So that's where Botox arrived. And I know you're probably familiar with Botox, but let me just remind you of the story of Botox. It's actually the reverse of the story of a CGRP antibodies. Botox was tried in ladies in the 80s who received it for cosmetic reasons. And these ladies were in their 40s and 50s and 60s. These were the women with a high risk of chronic migraine. So it was a natural population due to happen. And they noticed the effect of Botox. Nobody knew why it would treat migraine, They tried to treat episodic migraine. It failed in 6 trials. And then the company said, there must be something there and some money to be made. So let's look at, the most severely affected chronic migraine people. And that's what they did. And then they hit the jackpot because they actually did two positive studies that were called the preamp protocols. And then after that, there was a huge response of the scientific community saying, why is it working? And from that, we learned that Botox inhibits the release of CGRP, substance P, the expression of the TRPV1 receptor. And that happens actually mostly at the peripheral level. But this has effects to the trigeminous nucleus caudalis inside the brainstem. So the idea is that Botox actually has a peripheral effect that modulates the system centrally. And even more, we learned actually from these studies that there are little fibers that actually go through the sutures of the skull back to the meninges. So that's pretty cool. So it means that when you inject the skull, you might actually inject branches that go back to the dura directly. So that was also very surprising. So Botox, if you wonder who should get Botox, any person with chronic migraine, and particularly if they failed 2 or 3 oral preventives. That's a question of coverage. So insurance, including RAMQ, is not going to pay for Botox if there's not been 2 or 3 failures. It takes 2 or 3 cycles to observe the response, which is 6 to 9 months. The success rate of Botox is 50 to 60%. And that's huge because with chronic migraine before, I can tell you that the oral preventives were not that good. It's very well tolerated. It does not interact with anything. It is safe and it's sustained effect over years of therapy. And I've been injecting it for 10 years now. And I can tell you, usually a Botox responder keeps responding, fluctuates, but keeps responding. I will remind I have conflicts with Allergan because all of this seems extremely positive, but quite frankly, it is. So now let's switch to the new revolution. So triptans in the 90s, Botox in 2010, and now CGRP antibodies. And I will take Erenumab as an example, but this applies to the whole class of CGRP antibodies. So CGRP was actually studied as a vasodilator because it's a very important vasodilator. It actually acts in situation of ischemia. That's what it does. And because migraine in the 80s was still perceived as a vascular headache, well, it was very natural for migraine people to look at CGRP. But then people understood that CGRP was more than a vasodilator. It actually also played a role in the pain system. And from that, the first GPANs, the CGRP antagonists, were developed. But then they failed, and Merck lost tons of money because of hepatic toxicity. But then the antibodies were developed. So in 2008, 12, and 16, and now we have the CGRP antibodies on the market. So that's really the story of CGRP. It's 20 years of hardcore research and clinical trials. So CGRP, do we have a rationale that it plays a role in migraine? Absolutely. So we know the serum levels are elevated during migraine attacks. We know if we infuse people with migraine with CGRP, they do that in Denmark, you can actually trigger a migraine-like headache. Interestingly, you do not trigger the aura. That's kind of cool, right? You trigger the pain system, you do not trigger the cortex. Triptans do reduce CGRP levels. So maybe triptans are not all about serotonin after all. And selective antagonists to CGRP actually treat migraines. That's the world of the GPANs, because the new GPANs we have now are actually liver safe and will come to our market soon. So in more detail, where do the CGRP antibodies work? They do not cross the blood-brain barrier. So they do not go centrally apart in zones that don't have the blood-brain barrier. And some of these zones are relevant, but I will not go in too much detail there. There is a ton of CGRP inside the parenchyma of the brain. And this, we don't know exactly what the CGRP does there, right? So I think it might be actually a good thing that antibodies do not cross inside the brain. So where do they act? They act on the dura, on the dural vessels, on the ganglia, and they act on the blood vessels of the dura. So all of these structures are heavily involved in pain sensation, and we believe that's where they work. How many of these do we have? We have 3 at present time, and a 4th is coming. So all of these antibodies are injectables. They are injected once a month, or in the case of the EPT and Ezumab, it's an infusion every 3 months. So this is completely different than taking a pill every day for patients. And so you might have heard those names: Aimovig, Emgality, Ajovy. All of these are between 550 and 600 something per month. So that's a few $1,000 per year. Just comment, we pay $50,000 to treat multiple sclerosis. So I think for chronic disabling migraine, this is reasonable. But so we have these. And this is my super ultimate one slide, because I give slide kits about this for the last 3 years. This is my one slider. So CGRP antibodies do not interact with oral medications. That's kind of cool. They are metabolized through the reticuloendothelial system, so not the liver and not the kidney. That's probably a good thing. Their 50% response rate on migraine attacks is 50 to 60% for episodic, which is actually a little bit better than oral prevs. And in chronic, 40%, which is a little bit lower than Botox. There are super responders. So people who respond 80% to these, that means going to 24 attacks per month down to 7 to 8. Massive impact. So actually 20 to 30% of people are super responders to CGRP antibodies. And this is really something that's life-changing. They can work quite fast. The response is sustained in the majority, not in all. Some people lose the effect. We don't know why. The tolerability is good. There's some allergy, injection site reactions. Constipation has been a big one. Contraindicated with pregnancy. You cannot do this. You can do Botox. Now, most people agree, but you cannot give CGRP antibodies with pregnancy. And there's no indication in children and teens. Their studies are ongoing. Most of us will have caution with vascular disease, even if FDA and Health Canada make no recommendations, just due to the role of CGRP in vascular vasodilation. What about pain, right? So I told you about CGRP for migraine, but I told myself, is CGRP playing a role in pain and sensory fibers? So is there any study on pain? So this is a graph from a 2017 study done by a headache team. So they might not, understand the whole the whole pain world, but they did review the literature. It's interesting. I read the paper a bit through, but there are notions of increased CGRP levels in different tissues in different pain conditions, but the correlation between CGRP levels and pain levels are not always clear. So there's no consensus, and this is on a very vast array of different diagnoses. And migraine is one diagnosis with diversity, but still, when we say pain, of course, it can be fibromyalgia, knee pain, other type of pain. So this still, but I think if you need a paper to review CGRP, there's this one. There's one more recent that I could not access that's been done in 2020. One study has been done with galcanezumab, which is a CGRP antibody for knee pain, and it was negative. And a lot of us are now hoping to see trials on migraine people with fibromyalgia, for example, and see are they benefiting from the CGRP antibody for fibro. Another big open question is, what is the effect of CGRP antibodies in people who take opioids? Because these patients have been excluded from studies. And why? It's just usual in migraine studies to remove people who take opioids, because opioids are perceived as very strong sensitizers of the brain. And usually the companies don't want to take that risk. It's too bad though, because it's of course a very disabled population. All right, so little philosophical comment here. Migraine has been so stigmatized over the millennia. It's been described as a disease of whiny women. And even in my training in neurology, most of my teachers didn't want me to go to headache medicine because I was losing my career over stupid, depressed, fibromyalgic women. I heard these comments seriously, and there's a stigma on patients. There's a stigma on physicians taking care of headache in general. This has to change, and it is changing. But I think the triptans helped a lot. And I think CGRP antibodies are going to change the way we see migraine, because quite frankly, and Botox the same, because for migraine patients, when I've seen a lot of migraine patients who've lived with migraine for 30 years and they fail the oral preventives, and they are doing yoga, they drink water, they practice meditation, they went to MBSR training, they did everything. And a lot of them actually do not have significant comorbidities for health, medical or mental, apart from the consequences of living with this disorder. And so when you see such patients and you kind of put their failure on their shoulders saying, well, it's because, and the whole world tell them that, their neighbor, their healthcare provider, their insurance company, their uncle. And when you give this patient a CGRP antibody or Botox therapy, and they become normal again, and they can drink wine, and they can train, and they can go out, and they don't have headache anymore every day, that makes you pause and say, how many others are there that we're blaming for their headaches and we're sending to management sessions and telling them they have to behave differently and all they need is specific therapy? So this is something that I've been thinking about quite a bit. um it's a bit scary, quite frankly, because you say, oh my god, all they need is that we treat their migraine and then they can just live their lives. So it's very eye-opening. On the other side, some patients do need behavioral interventions, and their lifestyle is key to their pain management and their migraine management. And then we hit the interesting question about where do we send these patients for management? All of these things have been tried for migraine and BSR, CBT, ACT, all of this, different diets, different exercise. Occupational therapy is actually very interesting. And here I will share, my experience in Calgary, because I work both in the pain clinic and in the headache clinic. And in the old days of the pain system, the pain program there, they had a headache track. So patients were sent to a session on headache, and they had specific headache sessions. The headache track was canceled, and then the headache people were saying, headache is pain, that's all pain, they need the same thing, let's send them to the pain sessions. And then patients hated it because they were like, you know what? This is not me. I'm not like these patients. My problem is brain fog. My problem is photophobia. My problem is attacks. My problem, I'm not taking opioids. I'm taking triptans. I have medication overuse with triptans, has nothing to do. And so patients did not feel like they were belonging. They also did feel that all the talk about how to manage chronic pain, a lot of it did not apply to them. Because all the story about confronting your triggers, increasing your resistance, does not apply to migraine. Because in migraine, if you confront a trigger, you will have an attack and you will suffer and you will have more sensitization about due to it. So it's very difficult. I think this is one of the discussions I think, and I hope we can keep going, about the needs and how to collaborate and how can we actually, because at present time there are no multidisciplinary clinics for headache in Canada, none. The one in Calgary is struggling. There's one in Toronto, I think they have a nurse. There's one in Ottawa, they have like an OT and a psychologist, but nothing organized. And some patients really need this type of approach. And I think in an adapted fashion, but that's a conversation to continue. So a few words about cannabinoids. And so I will actually say that it's been fascinating to read about cannabinoids, but I cannot claim expertise. But just to say in short that there's a ton of reason why modulating the cannabinoid system could be good for migraine, right? Um, Look at this, TRPV1, CGRP, cannabinoid receptors. Of course, endocannabinoid system modulate every neurotransmitter system in the brain. So you can find a lot of reasons why it could work. The problem is, and of course, patients just like experiment and they try a lot of things. The problem is we don't have data. This is the one study we have on medical marijuana for migraine. This is one of the worst studies I've ever seen. It's actually very poorly done. It's retrospective. They followed patients up to 3 years later, did not control for anything else that would have happened. And yet they actually claim an 85% decrease in frequency. But when you actually go to how many patients report that cannabis had a preventive effect, it's 20%. but that's what you see on the internet is 85% results. And interestingly, 11% of patients report that cannabis is effective as an abortive. That's not very impressive. So this is the data we have. I think there are more recent data with app analysis from strain print and so on, very limited data. The other word of caution is that THC, same lab, same Mayo people, rodent model from Poreka lab, that THC, no surprise there, it's a partial agonist of mu receptors. THC actually can produce allodynia in rats in a sensitization model. So it's an invitation to caution that cannabis could actually lead to medication overuse headache. That may not apply to CBD, which has a very complex pharmacology, as you know, but certainly a word of caution about using cannabis in chronic migraine. So my conclusions on over all of my cannabis review was that there is a scientific rationale. Phytocannabinoids are fascinating. They could be helpful for some patients through management of anxiety and sleep, because if you can get an anxious patient with migraine to sleep, you will help this patient. There's one study on nabilone for withdrawal of medication overuse. Cannabinoids can act as opioid-sparing agents, and patients love natural products. So that's the pros. Let's look at the cons. Well, the complexity of the endocannabinoid system makes it very tough to predict how the migrainous brain, that is particular, as I've shown you, is going to react to cannabis. And that's valid for the sensory system, for the vascular system. There's a lot we don't know. The evidence is limited. Doesn't mean it doesn't work, just say we don't know. There's the ratio THC CBD is very tough to manipulate. The content of products is difficult to control. And there are risks of cannabis, which you're all aware of, but particularly for migraine patients, medication overuse, hyperemesis syndrome, and RCVS, which is a vasospastic disorder of the cerebral arteries that is more frequent in migraine patients and may lead to stroke and brain hemorrhage. So no joke there. So I don't think I have time to cover all. I'll take a few more minutes about cervicogenic headache, but I will probably have to stop before the end, but that's fine. Because this is a very important aspect. We've all seen tons of this lady, 52-year-old. She has chronic migraine. She seeks your advice. She has daily neck pain, worse on the right, radiating to shoulder, and her attacks may be triggered by physical effort. Her osteopath tells her about neck tensions, her chiro about some misalignment. She's obese, deconditioned, and has diffuse pain. Someone said maybe fibro. She tried 10 different pillows. She's now using an analgesic, including codeine 20 days per month, so she has overuse. And amitriptyline helped a bit, and she wants to know, what should we do, right? So here, I want to underline here that 75% of people with migraine actually with normal necks report neck pain associated with their migraine attacks. So neck pain is a very common, and actually I have this myself. I have zero neck pain whatsoever, apart when I have a migraine and it goes right to my right neck. So the thing is, I think it's absolutely normal for people to look at things a certain way. And in migraine world, my colleagues are what I call centralists. All migraine is the brain and the neck is to be ignored, right? So there's like, no, we don't think the neck is like, we don't address the neck, and it's all for migraine pain. It's all central. On the other side, some people are actually, and in all types of work, will tell patients that their neck needs to be fixed and that it will be fixed. And I think that's bad, because if a patient with migraine does not get proper migraine care, you can do whatever you want with the neck. It's not going to settle the whole issue. So it's a two-way road, and we really need to kind of find ways to help these patients with a combined approach. So this is if the patient has migraine, of course. If the patient has no migraine and there's only pain going up from the neck, then maybe we can call it cervicogenic. But how do we do that? I would love for GPs to stop diagnosing Arnold's neuralgia. This is such a bane. This is Arnold Friedrich. He published a lot of great stuff. The problem with Arnold's neuralgia, for some people, the patients bite to that a lot. They like Arnold. I think it's an easy name for them to remember. I don't know. But most of patients with Arnold's neuralgia don't even have a neuralgia at all. What they have is allodynia of the deep tissues. They went to the emerge, someone pushed on their necks, they said ouch, and then someone diagnosed them with Arnold's neuralgia. So we really need to get away from that, because in real life, what we see is what? We see someone who had migraine, maybe had some degree of trauma, whiplash, an accident, or maybe some repeated movements, and then sensitized and then went into a version of post-traumatic headache, cervicogenic headache, migraine with neck pain. So that's the problem of classification, that migraine, and I didn't put migraine there, but the classification is made in a weird way. If you have a primary headache, it's all about symptoms. If you have a secondary headache, it's all about etiology. But post-traumatic headache can be a bunch of things. It can be migraine-like, it can be tension type-like, it can be a lot of neck, it can be a lot of dizziness, it can be just cognitive. So we should be very careful with that. And cervicogenic headache, as you all know, is very complex because they're telling us, oh, you need some evidence that there's a cause in the neck, and this evidence is usually impossible to get. And then you need to be able to treat these patients with blocks, which is a problem both sides, because blocks can be placebo, but they can also not work, right? So it's a very, very difficult diagnostic set of criteria. And to make it, of course, more complicated, and this is something you know better than I, but if I see a patient with neck pain, can be myofascial, can be facets, can be nerve roots, and can be pain matrix, can be a mix of all those things. And the problem is that really we can do a lot of stuff. We can do TPIs, nerve blocks, facet blocks, median branch blocks, rhizotomies, RFAs, ONS, and surgery. But who on earth can predict with symptoms, physical exam, or imaging who is going to respond so far? And I would love, love, love to do like a little, when COVID is done, so we can sit around the table and have a drink together and talk about this, because this is something I've been working on for years. And it's really tough to help these patients and to understand who's going to respond to what. There is a risk of harm, right, to do procedures in some of these patients because they can be deteriorated. I've seen that. And on the long term, like, is it good to do RFA every 3 months like they do in Calgary? I don't know. And of course, there is also a risk of placebo responses. So this is a tough topic. So I think I'll take the 3 last minutes to talk about cluster headache. And I cannot not do it because cluster is my, I do a lot of migraine, but cluster is my kind of so dear to my heart. I studied it during my fellowship. And so this is a primary headache condition characterized by attacks of unilateral pain, usually in 5-1 distribution with autonomic features. The attacks last 30 minutes to 3 to 4 hours, and they occur 1 to 8 times per day. You can see by the picture, this is called suicide headache because these patients have suicidal ideations during their attacks, and they sometimes will commit suicide, though luckily not that often. This is terrible pain. And in our world of headache medicine, we often say that cluster headache is the worst pain known to men and women. And I was surprised a few years ago when I heard the media bit about the McGill Pain Index that it was not even listed. And I actually went back online today and I tried to find the original, and I find a media thing talking about CRPS, which is horrific. I totally agree. But I think cluster should be there. And I was just wondering if cluster is not there just because it's not sent to the pain clinics, but it's something that should be on the list of worst pains ever. I do believe. I have no idea how the index is done or where it comes from, but I wanted to raise awareness about this very tough condition. I'll skip over that because when we manage chronic cluster, episodic cluster is usually fine, but because they have a lot of remissions and usually they can kind of go back. But chronic cluster is hell. Chronic cluster is like having these attacks every day, extremely tough. And I want to open a door here for research and collaboration because this is one of the best thing I've seen in years for cluster. IV ketamine with magnesium. This is a recent study performed by a French team with refractory chronic cluster who received ketamine and magnesium. 17 patients, I promise I can find 20, who went for 4 attacks per day to 1 attack per day. This is massive. Like I looked at this, 76% were 50% responders. This is an open label series. There should be a placebo response, but believe me, this is really good. And response was sustained for an average of 4 weeks with very mild side effects. So I at some point, you know, we're all extremely busy, but I think this, if we could replicate this experience, that would be fantastic. So I'll actually stop there. I'll skip on the slides and open for questions. But, you know, the question is really when I opened this door on when should headache specialists send a patient to the headache clinic? And when should the headache clinic send the patient to headache specialists? So I think that's kind of the open discussion as well. And as you can see here, I've listed a few ideas on both sides, but I think I want to take some time for questions. So I'll leave the conclusions and skip to questions.